Good morning, good afternoon, good evening, everyone. And on behalf of Project Hope, we're happy to have you all join us on our third Crossroads in Global Health webinar, and our first for 2025. As we all know, the year started with a bang, with shifts in global health as we know it, and cuts in our funding for global health programs, for humanitarian programs. So I know it's been a lot for a lot of us, and we just want to continue to keep the flame burning and continue with this really important work we do in this space. So for those of us who do not know Project Hope, I'll do a very quick intro. We are a global health and humanitarian organization, and we've been in operations for 66 years plus. Our core areas, working across over 30 countries in Southeast Asia, Africa, Latin America, and the Caribbean, Eastern Europe and Ukraine, US domestic, and the Middle East. Our core program areas include infectious diseases programming, HIV, TB, malaria. We have a big reproductive, maternal, newborn, and child health portfolio, non-communicable diseases. We're doing a lot around emergency response and humanitarian, including mental health and psychosocial support. I would say that at the heart of our work as Project Hope is a really deep commitment to strengthening the health workforce and also ensuring access to quality health services and strengthening health systems resilience. So last year, we did launch this webinar series called Crossroads in Global Health, and basically launched and started to spotlight critical areas shaping global health. And our previous two sessions had focused around climate health, climate and its impacts on women and children's health. Our other focused on, I think the October series focused on supporting the mental health of frontline workers. And so today we would be having, like I said, our first session for the year, and it's focused on a very important area, which is the role of midwives in humanitarian and fragile settings. We do have with us today very amazing speakers from all over the world, Pakistan, Gaza, and other places who kind of walk us through the challenges and the realities on the ground in these conflict-affected areas, and how midwives step in to close the gaps or address the gaps in those areas. And so I'm very pleased to have Rondi, our dear colleague and Senior Technical Advisor for Reproductive, Maternal, Newborn, and Child Health, who will be facilitating the sessions today. Rondi, are you here? I'll hand over to you to take it from here. Thank you very much.
Thank you, Uche. Hi, I'm Rondi. I'm a midwife and also a public health person, and I have worked in a lot of humanitarian crises in several different countries, most recently in Gaza. And Project Hope has a focus on humanitarian crisis. We've recently responded to earthquakes in Morocco and Turkey, and very recently in Myanmar. We also are in conflict-affected areas. We have ongoing active programming in the Ukraine and in Gaza, and we're in places with political turmoil like Haiti and Venezuela. And so we are very interested in how to improve the quality of the work that we do. And one of the things that we do is provide healthcare. So today, our focus is on women's healthcare and on how midwives can support girls and women during these very vulnerable times. There is a basic package that the global community, including the Sphere Standards, delineates for what women need, and the presence of midwives and the competencies of midwives allow them to be best positioned to reach the most vulnerable. We'll talk more about specific details of what that minimum initial service package for sexual and reproductive health is, and also what the scope of midwives is. But first, let me introduce our my esteemed colleagues and our very expert speakers. The first one is Dr. Poonam Durdana. She is currently in Pakistan. She's the CEO and founder of the Kuti Research and Development Pakistan, and the co-chair of the Maternal Newborn Health Sub-Working Group for IWAG, the Interagency Working Group on Reproductive Health in Crisis. She's recently been the senior consultant investigating maternal newborn health in Gaza, and her profession spans 27 years. She's worked with WHO, UNFPA, UNICEF, and UNHCR. So welcome, Poonam. Next is Rita Al-Madoun. And I had the distinct pleasure of working with her and seeing her amazing work in Gaza. She is a midwife and a nurse, and she definitely qualifies as a young midwifery leader. She graduated with her midwifery degree in 2022 and her general nursing degree in 2024, and then she also studied palliative care in 2022 and 2023. Before the crisis, she worked as a midwife in the Ali Arab Hospital for a year, and then since the crisis, she's worked both with UK Med and also with Project Hope, providing primary health care, so outpatient antenatal care and family planning and some response to gender-based violence and screening, and also with labor and birth. Our third speaker, Stephanie Marriott, is currently a midwife advisor for the International Confederation of Midwives. She is based in Den Haag at their head office. She's a midwife with a master's degree in public health that she got from the Liverpool School of Tropical Medicine. Before her current work, she spent 6 years working in low resource and fragile settings, including India, where she supported midwifery education and midwifery models of care, in both Bangladesh and Malaysia, where she supported the Rohingya refugee crisis. She and I worked together in Bangladesh, and in South Sudan, where she supported midwives during humanitarian crisis. So I welcome these experts, and I'd like to begin our conversation. My first question is to Dr. Poonam. What are some pressing sexual and reproductive health concerns and challenges that you see across all humanitarian settings? We're interested in general themes, but also if you have specific examples.
Thank you very much, Rondi, for such a very important question, because as you know that midwives are basically the lifeline in any humanitarian crisis. So the basic challenges which I've been observing over years is their accessibility in terms of high security alert conditions. Then when they are not equipped with the drugs, medicines which are required as for the emergency obstetric care, or if they are not able to refer the preterm children or identify the high-risk pregnancies and their referral challenges. These are all the main challenges which exist all across the world. While if I may quickly share the example of Pakistan, that in Pakistan during flash floods 2022, and specifically for the polio program, and also during the earthquake 2005, the role of midwives had been extremely wonderful, commendable job. They had been involved in providing safe delivery kits to the mothers. They have been doing deliveries in the tents, and according to the records, there were 12,000 emergency deliveries which were conducted in tents during the Pakistan floods in 2022. Likewise, they had been providing emergency deliveries, neonatal resuscitation, like treating arranging for the transport by making some local arrangements. And also during any outbreaks, As I said, that polio program is one of the key success story for especially the lady health workers in Pakistan. Their involvement, they are able to reach children inside the houses where there are men are not allowed, vaccinators are not allowed. So all of this, besides that, they also do community education and early warning, like earthquake preparedness or any disease outbreak preparedness sessions for the community. They also help in advocacy and also in data collection, which is very much required for any policy level decision making. So it's basically community midwife is the one who is eyes and ears of all the policymakers. I consider them like that.
Thank you very much, Poonam, and thank you for giving us some examples of what it really is like in the field, and highlighting the fact that midwives are there in the field providing care. I wonder about you, Stephanie. Could you also shed some light on the concerns and challenges in these difficult situations?
Yes, absolutely. So one of the things we see often reported by women is that their experiences of disrespectful care in humanitarian settings. So care that may not be respectful of their rights, of their needs, that may be abusive, but also that is disjointed and not in a line with what we call a midwifery model of care. So this is a model of care where the main care provider for women and newborns, starting before pregnancy, continuing all the way through to the postnatal period, are educated, regulated and licensed midwives, and they autonomously provide, coordinate, and arrange respectful, high quality care across their full scope of practice, using an approach aligned with what we call at the ICM a midwifery philosophy of care. So in humanitarian and fragile settings, often seeing the same midwife is not possible. For example, if there's been displacement, you may not be in the same place throughout your pregnancy. But the hope is with a midwifery model of care that they can continue to see a midwife who will have the same philosophy, which hopes to overcome some of this disrespect that we often see in these settings. Thank you.
Thank you, Stephanie. Yeah, the midwifery of model of care and how that ensures that women get quality, but that they also feel respected when they access health services. We know that those are issues really everywhere globally, but they are particularly issues in these fragile settings. So yeah, thank you for that. So my next question is for Rita, and we're interested, Rita, in how your role and women's healthcare changed when your community was faced with a humanitarian crisis. We're all very aware of the tragedy that's going on in Gaza, and we know that before this crisis, you were working as a midwife in a fairly well-functioning health system, and then you had to adapt, and you did. So can you talk a little bit about what that was like for you after the crisis? How was it different to work as a midwife? And also, if you felt like sharing over time with this crisis, how did things change for you as a midwife and for women in the needs that they had?
Thank you, Rondi, for this important question. Before I was working at delivery room. I were providing labor support, delivery services, and medication administration. Our cases was fewer than now. The high-risk cases was lower than now. So our work was easier in comparison with now with fewer emergency conditions. We were devote more time for individual patient, building relationships and providing personalized care. But during the war, because of limited area and crowding of the people in a humanitarian area, so we are dealing with a huge number of the patients. We provide at our clinic PCC, ANC, postnatal care, family planning, and breastfeeding support, hygiene promotion, and health education. We are dealing with a huge number of high-risk cases like malnutrition, anemic cases, vaginal bleeding, and other pregnancy complications. This makes our work harder than before. Also, the work environment is poor with limited resources, limited equipment, supplies, and medication. Also, our responsibility increased and our urgent and emergency condition increased. Some midwives facing precipitate labor, or some ladies deliver at the tent, which lead to maybe to postpartum hemorrhage, to bumping during the displacement. We provide the psychological support to the women dealing with the stress. We noticed a huge number of women facing many challenges like stress, fear due to bombing and fire. And we at our clinic we provide ANC for 13,484 mothers, and 15,500 women received education and hygiene promotion. So this indicates that we are dealing with a huge number of the patients and women.
Thank you so much, Rita. And it's heartbreaking, I'm sure, for all of us to hear your words. I think that I like that you brought out that one of the big differences that before you could sort of give individualized care, and now you have many, many women with many, many needs. And so your role has expanded greatly. Like before you were a labor delivery nurse, and now you are doing a wide range of public health response and responding to lots of women. Were you wanting to start to say something? Yeah, thank you. So I'm interested to hear from Stephanie, what she's talking about, what Rita is highlighting. Is this typical? Do you hear about these kinds of things from other contexts? Can you add to what Rita has shared with us?
Yes, thank you. And thank you, Rita, for sharing. So what she's described is this expansion in scope of practice of a midwife, that before crises, midwives' roles are often very clear in the context that they're working, but during crisis, that this role changes so that they're doing more of the scope of practice of a midwife, and maybe even other roles, other public health roles like Rita described. And we know that midwives are often first responders. They're living in the areas affected by crises, and they're known and trusted and often more accessible than other health workers in the community. The other thing we see in humanitarian and fragile settings, particularly in conflict, is an increase in the scope of practice of midwives around the management of sexual violence. So we see that becomes part of the role of the midwife clinically, but also that they begin to work in partnership with other workers from protection sectors. And so, for example, I've seen this working in Bangladesh, where midwives were based not only in health services, but also in women-friendly spaces in a protracted crisis of displacement, and also in South Sudan, where it became part of the full scope of practice of midwives to be providing this support to women surrounding GBV as well.
Thank you, Stephanie. Yeah, really, really insightful and good to highlight that sexual violence, that unfortunately, both during conflict, sexual violence can be an issue, and also when people are living in very crowded situations. So the risk of sexual violence increases, and it means that the midwives need to expand their scope of practice. Dr. Poonam, I'm interested to hear from you. Can you share with us if this is what aligns with your experience, and talk to us about that a little bit?
Yes, sure. Thank you very much, Rondi. I would here very much want to share the experiences of Pakistan with regard to the CMWs, like the community midwives, that according to the Pakistan Demographic Health Survey, it was noted that the family planning counseling was a very key component which community midwives were involved, and they promoted birth spacing, and they were able to increase the uptake of family planning by 25% in the community midwife served areas. Likewise, we have observed the maternal and neonatal mortality reduction by CMWs, almost about 30% in the rural Pakistan, and it is according to the WHO estimates of 2023. Likewise, they have been very much involved in the in preventable deaths of the newborns, and it has been the preventable mortality has been dropped by 20% where CMWs were active, and these figures are according to the UNICEF 2022. We have been also seeing that the four like the recommended antenatal care visits, but at least 4 visits have been observed in the CMW supported areas, almost 55%, and overall the postnatal care within 48 hours have been increased up to 60% in the areas where the CMWs were there. In Pakistan, we have 4 provinces and federating areas. So in Punjab, which is one of a very heavily, thickly populated province in Pakistan, there's a success story regarding the Punjab CMW's initiative. And that project was for 2018 till 2023, and it trained 5,000 CMWs, which resulted in reduction of 40% of maternal deaths in the rural Punjab province. Likewise, 30% increase in the institutional deliveries. And in another province, we had the Sindh Mobile CMW Clinic. It was during the 2022 floods, and they were able to provide emergency deliveries for 12,000 women in flood-hit areas. And but of course, there are a lot of challenges which are being faced by CMWs. There are limited resources. There are almost 40% lack of delivery kits, oxytocin, and other drugs which are required to facilitate their work. So there are other challenges in terms of reaching the high-risk areas, high security alert areas in Pakistan. So CMWs, there is a lot of room and lot of space to work for CMWs in Pakistan and across the world, where you can prevent the preventable maternal deaths and the neonatal deaths just by investing in CMWs. Thank you very much.
Thank you. And the very impressive numbers. I hope that all got written up in articles, because there's a lot of best practices for us to learn from that experience. And I know that I have read some of it, some of that research. And you did a nice job also of making the segue into this minimum initial service package that I'll talk about in a little bit of detail, but you brought out the contraceptives, and you also brought out the reduction of the newborn deaths. And when the sphere, the standards, which are a global guideline in terms of what we want to make available for all people, even those in the most critical humanitarian crisis, we have this reproductive health minimum essential care package. And it's the goal of everyone that's responding to a crisis to make sure that girls and women have this basic package available for them. And the basic package, the goal of it is to prevent morbidity and mortality in crisis. And one of the overarching, there's 6 components, and the first and the last are more organizational, but the first one is that you need a lead agency that will coordinate and support all of those who are implementing, and typically that falls under the World Health Organization health sector or health cluster. That UNFPA leads the coordination of this minimum, of all partners that are providing this minimum package. But then the package includes health response to sexual violence. So as that came up earlier, I think both with Rita and Steph talking about midwives' expanded role into sexual violence, prevention and treatment of sexually transmitted infection, reduction of maternal and newborn mortality, and typically that's focused more on emergency care. So oftentimes organizations want to go in and provide antenatal care, but really it's that 24/7 emergency response that reduces the most deaths, and prevention of unwanted pregnancy. So making sure that all women have access to contraceptives. And then the sixth one is that as soon as possible, we want to expand into comprehensive sexual and reproductive health care, so that the women in crisis have access to the same comprehensive care that all women do. And oftentimes that means working within the health system, the existing health system. So trying to strengthen the existing health system to be able to absorb the women in crisis, which often takes time, but we want to start it early. So I want to start this conversation by asking Stephanie to talk about the minimum initial service package, and how that ties into the recently endorsed by WHO midwifery models of care. What is the role of midwives within the MIS package, and how does that change with context?
Thank you, Rondi. So as I defined before about a midwifery model of care, so this is a midwife being able to provide care from pre-pregnancy right the way up to the postnatal period for the mother and the newborn. And we also know that the scope of practice of a midwife includes more broadly other elements of sexual and reproductive health. And what a midwife can do within that model of care is work autonomously. And the reason they can do that is because when they have their pre-service education program, this aligns with the International Confederation of Midwives' essential competencies for midwifery practice. So if you're not familiar with these set out the knowledge, skills and behaviours a midwife needs to have to work across the full scope at the point of entry to the profession. So essentially the scope of practice sets out the boundaries of what a midwife can do. And the 6 functions of MISP map directly to these essential competencies and the scope of practice. So this means that when a midwife is educated and regulated to have achieved these competencies in their pre-service education, they are able to provide all functions of MISP. And this means that they are ideally placed to be first responders in humanitarian settings as well as other stable settings, and also that they have the skills to be the leaders. So you mentioned about function 1, the coordination of MISP through the health sector, and function 6, the planning for comprehensive care, so through the WHO 6 building blocks for health systems. And we see that midwives are also able to lead in those situations as well, because of the essential competencies, the basic knowledge and skills that they have. But context sometimes changes this a bit. So as I mentioned before, midwives' role encompasses more sexual violence response in crisis. And so during conflict, midwives might work in partnership with other professionals, such as those in the protection sector. But this is also part of MISP to respond to sexual violence. We also see that midwives work in different settings, maybe in mobile clinics, I think Rita began to discuss about distribution of dignity kits and commodities, maybe clean delivery kits where a health facility is not available. And then locally, we might find that if a crisis occurs in a setting where before there was a well-functioning health system, midwives might be expected to provide aspects of care. So a good example is distribution of antiretroviral treatment for community members with HIV. Well, pre-crisis, that might have been done by a specialist service, but now it's the midwife. Thank you.
Thank you, Stephanie. And sorry that you're struggling with your voice a bit, but really good points that you bring out, this alignment of what the minimum initial service package delineates for all women and the scope of practice of midwives. And I once was giving a talk on this, and somebody in Geneva who had been part of designing the MIS package said, we did that on purpose. We worked together to make the midwife competencies be the same as the minimum initial service package so that we would do what we could to make sure that there was a healthcare provider available for the women. So I'd like to turn this over to you, Rita. Can you talk about your role in providing the minimum initial service package in your context?
We take a training about GBV and the clear referral pathway and follow up the protocol. We do awareness raising between the women about their rights and how they can protect themselves. We offer different family planning methods and services. First line support by paraphrasing and doing assessment by asking and listening to the women who suffered from maltreatment or violence. And we ensure safe delivery without complication. As we know, our goal at the MISP is to decrease maternal and newborn morbidity and mortality. We provide treatment for recurrent UTI and vaginitis and provide the appropriate treatment and management. Any woman was exposed to the violence or maltreatment, we provide emotional and psychological support for her and treatment of STIs and give emergency contraception. We also provide nutrition support as we noticed that the malnutrition cases increased in Gaza during a crisis, and we tracking anemic women and provide supplementation and care as needed to reduce the complication of pregnancy, furthermore the complication of postpartum period. Yeah.
Thank you, Rita. That very impressive. It's so touching because we know how hard you're working and we know the vulnerability of the population that you're taking care of. And you did such a good job of describing how the comprehensive work that you're doing. And I know that you're doing it 24/7, even when you're at home and when you're at the clinic. And thank you for all that work. So I'm going to move on to the final discussion, and then we'll be opening it up to questions. But this is we want to hear from all of our experts. What do you feel most proud of in your work? I know that many of you have been in different places, and you've had a real commitment to this. So please share with us what you feel like has been most satisfying for you in terms of what you were able to do or how you were able to support people. And maybe I'll give it to Poonam first. Let's hear from you.
I would say share a very different experience of our own organization while working with CMWs. We trained them as entrepreneurs. Like the CMW workstation was we provided them a very small stipend with the help of which they opened a grocery store or a small toy shop or any small items which people or the women who are approaching them in the rural areas were able to shop and spend time with them, because in our cultural and rural settings, usually females, they are not like without men, they are not allowed to go out to market. So, and obviously for visiting any CMW workstation, they are accompanied by their mother-in-law. So they were provided an opportunity, like the mothers were, like the pregnant ladies were provided an opportunity to visit the CMW workstation, get their checkup done, and at the same time do some shopping. And the midwife used to raise that money and circulate it for getting their businesses developed. And this model, and we provided them with some financial management guidance and advice, and trained them on the financial management curriculum as well, which was developed by our organization. So, and indeed, it was a very, very good to see that like they flourished as entrepreneurs beside being the CMWs. So this was a very heartening to note that if you provide good environment and opportunity, the females also thrive.
Yeah, I love that example of how we're empowering women and really empowering communities through midwifery. So that's nice to hear and a good example. Stephanie, can you tell us what you feel proud of?
Yeah, thank you. I mean, I think mine would be that midwives are able to be these first responders in crisis. So they show resilience in settings that are not only fragile, but often dangerous. They're demonstrating resourcefulness when they often have no resources. And what we see is that it's often more than that. So they begin, and this is a bit how Poonam was describing, that they start to work as advocates for human rights in their communities, especially for women and children. And so we often hear at the ICM about, through member associations, midwives associations, that they utilizing that the connections that they might have with political leaders or NGOs to not only improve midwifery, but to improve the lives of women and children particularly, which is I'm immensely proud of.
Yeah, that's very nice to bring that out, that that midwives as advocates, and certainly midwives can have a reputation of being a bit difficult because we fight for our cause, and so it's great to see that globally now we become leaders and advocates for women. Rita, can you talk to us about what you're proud of?
Thanks for this beautiful question. I'm proud of myself that I am a dedicated midwife. I always strive to advocate about women's rights, provide appropriate and the best care for the women and their family. I remember when I finished the high school and told my teachers that I want to be a midwife, they told me women and their babies will be so lucky to have you during the labor and delivery. So this motivate me to do the best. I'm also proud that during the war I'm tracking anemic women, and I noticed a very, very noticeable improvement in their hemoglobin result, and the outcome of the labor was so satisfying. Yeah.
Thank you, Rita. Yeah, and thank you for being brave enough to highlight yourself. That's one way that we become empowered by women, is that we can stand tall and say, I do good work. And so thank you for that. I have a couple minutes, and I know that there's quite a few people from Bangladesh in the audience. And so I just want to say that I think in terms of my work in humanitarian crisis, at least one of the things that I'm very proud of is the young midwives in Bangladesh who responded to the Rohingya refugee crisis. And I was part of making it so that they could go. And we had, during the initial phases, and up until now, so for the last 6 years, we've had a few hundred midwives and young midwives, recent graduates, leading the minimum initial service package response. And Stephanie worked more closely with it than I did. I was at the Capitol and she was right there with the midwives. But for me, that will always be something that I will feel proud of in my career. So, thank you for all of that. And now we're going to talk about our call to action and how can we best support midwives and best support the International Day of the Midwife and best support quality care for girls and women, quality women's health care. Poonam, can you share with us some ideas about what we can do to support women in fragile settings?
Thank you very much, Rondi. This is a very important question, and it's a call for action that we should be very much focused to invest in the integration of midwives into disaster response plans. We should be working towards the capacity building of midwives in psychosocial support, in the mental health protection, and also in advanced trainings in the crisis care or in the how to provide support during humanitarian care. And beside that, it would be very important that the community midwife workstation must be supported by installation of the solar panels. So if there are any breakouts or any other during any other crisis, they are able to deliver and to perform with the help of the solar batteries, and because they, in any which case, they are the frontline workers. So that is my submission here. Thank you.
Thank you. Create enabling environments for midwives. Yes. Yeah, that's a very important one.
And also provide them with a good stipend.
Yes, compensate them for what they're worth. Yes. Stephanie, do you have more to add to that?
Yes, I can, and Poonam leads quite well into what I planned to say, really, which was that we've talked today a lot about certain types of crisis, but also we've not considered that many of these crises are also created by climate change. So exactly one solution to that is having solar panels, but also that midwives care for often the most in need in the most difficult of circumstances with very little resource, and despite this incredible resourcefulness and achievement, they're often left out of conversations about how we plan and manage crises, and we can change that. So the best way we can support midwives is to ensure that they're supported, as Poonam described, as the responders, but also we recognise them as leaders in emergency preparedness and response planning. So we advocate to protect them, but we advocate to include them with education, with sufficient supplies, the enabling environment parts you talked about, and having a seat at the table when we're planning for disasters before they happen as well. And so I would say kind of now as midwives, what we can do is that if you're not already a member, become a member of your National Midwives Association. With that collective voice, we're powerful, and it's a tool for advocacy that we can use to prepare for crisis and during crisis. And if you don't have a midwives association in your country, contact ICM. We'll help you create one. And this Monday, you all know, but it's this Monday, the 5th of May, is the International Day of the Midwife. So hopefully you're already joining events. We'll be able to share with you the ICM's toolkit for this year's IDM, which if you've not already started preparations for a celebration, you can have one. We'll share details of the event that the ICM are running on IDM, and then you can hear that collaborative voice to share with others. It makes you stronger as a midwife to see how midwifery is working in other countries, but also use it as an opportunity to share about why midwives are wonderful with politicians, with the families that you might care for, other healthcare workers, particularly in humanitarian crises. Midwives are always amazing, but they're extra amazing in humanitarian settings.
Thank you, Steph. That's good guidance for all of us. And I like the highlight on the political, like the policymakers, and how do we make sure that we pre-position for emergencies and that we have the human resources ready to be able to respond quickly. But also, even in general, in development settings, how do we make sure that the policy and the strategy and guidelines are all in place for midwives to be able to perform to their highest potential. And yes, there's many events coming up over the Midwife Day, so please tune into them. I think some of them are in the chat. So now we'd like to open it up to questions from the audience, and I think that my colleague Kristen is going to help with that. Do we have questions? Yeah,
yes,
please.
we do. Good day, everyone. Kristen Anderson, also with Project Hope. I just wanted to mention that in the chat, we did place a call to action with some good links to ways that you can get involved and help to support midwives. So please have a look at that. The first question is, how do you maintain midwifery education in unstable conditions? And what support, if any, can ICM provide to associations in crisis?
And maybe that for Stephanie, or
yeah,
whoever.
I can go ahead and answer. Yeah. So regarding midwifery education in unstable conditions, so it depends upon the type of crisis and how long it's affected. So we all learned from COVID that there are opportunities for online learning that can be utilized, but in some situations that might not be possible. But we would always encourage midwifery education programs to think about how they could do hybrid learning. So have options for students to access resources and classes online. You also might consider having a flexible program so that students can, if they're displaced, maybe they have to flee a country, and they provide what we call recognition of prior learning. So an opportunity to join an education program partway through in another country. And a way that you can ensure this flexibility is making sure that your education programs align to the ICM essential competencies, so that a midwifery education program in one country is very similar to that in another, so that your students can have that flexibility. And regarding what type of support can ICM provide in crises, it really varies. It might be that you have training needs. It might be that we can help you connect with donors who are able to provide support for commodities or staffing. What I would say is that be a member of your member association. Your member association is a member of ICM, and they can contact us. And if, again, you are not a member, you are in a country without an MA, you can contact ICM directly through our website. And thank you, Kristen, for sharing our website in the chat.
Thank you, Steph. Great answer.
Yeah, thank you, Steph. The next question is from Gaza, and it's from an obstetrician practicing in Gaza, and he's wondering why ANC is not part of the MISP package. And he's noticed from his own experience that the lack of ANC care has led to, obstetric complications. Would someone like to speak to ANC as part of the MISP package?
I could answer that. Does any of the experts want to answer it? So why don't I go ahead? ANC is critically important. It's vital and absolutely right that ANC does prevent complications. I think that the point that is being made in the MISP, and that I made a little bit, is that women die from time pinch emergencies. All the leading causes of maternal death and a significant portion of the neonatal deaths are critical emergencies. And that's true in all settings. I mean, for the most part. No matter how good your ANC is, women are still going to die from emergencies. And so sometimes people hope, oh, well, we'll just do really good ANC and then we won't have any complications. But that's not what we have ever seen globally. There's no example of that. That the first thing that you have to do to be sure that you're saving as many lives as possible is have 24/7 emergency response. So for the MISP package, that's what it's talking about. It's saying you can't go in and just have ANC, but not have 24/7, or women will continue to die. That it's much harder to set up the 24/7. I mean, sometimes there's exceptions to that. And Gaza, I mean, I think in many ways for a long time has done an amazing job at keeping 24/7 emergency services up and running. But other times it's very difficult to have those services available. So people do ANC, but they don't do the 24/7. So that's the point. The point is we need to maintain that 24/7. Dr. Poonam, over to you.
Dr. Poonam, you're on mute.
Yeah, can you hear me?
Yes.
Yeah, okay. I'm saying that MISP, ANC is not optional in MISP, but it's a life-saving priority. Like it is integrated into the first phase of the humanitarian response, like pre-positioning of the antenatal care supplies, TT vaccinations, iron tablets, folic acid tablets, likewise training of the midwives. All of these are a part of ANC, and we cannot exclude, we cannot say that ANC is not a part of, because if I may give an example of ANC in Rohingya refugee camps, 200 midwives were trained for the ANC outreach. Likewise, the clean delivery kits were distributed, almost 10,000. So all of these and the ANC indicators of the percent of pregnant women with at least one or more than one antenatal care visit is a part of this FAIR standard and also of the WHO. Likewise, percent of women receiving TT2 vaccination, and for percent of women screened for anemia and syphilis and other STIs. All of these are a part of MISP package. So ANC is a part and parcel of MISP. I would like blood pressure monitoring, malaria prophylaxis. So this is I would like to mention here.
Thank you. Do we have more questions, Kristen?
Yes, thank you. So we have a midwifery student who's joined us from Bangladesh, and she has a number of questions in the chat related to the lack of midwifery teachers in her setting. Said that there are some through private institutes, but at the government institute, they're not. And so I think she's looking for what kind of training opportunities or support specifically could ICM offer. And I guess, Steph, it would be also useful to know if there is an ICM chapter in Bangladesh.
Thank you, and good question. So yes, there is an MA, the Bangladeshi Midwifery Society, BMS, in Bangladesh. So if you're not already a member, Sana, please join. Regarding faculty, so midwife teachers, it takes a long time to establish faculty in midwifery if midwifery doesn't already exist in a country. So from experience, what happened in Bangladesh is that initially they used nursing faculty, and then they gave them extra training opportunities to then transfer to be midwifery faculty. But this takes time for them to gain the knowledge and skills to change over. So there is a technical specialist issue that if you don't have midwives, you don't necessarily have midwifery faculty. But then there is a bigger higher education issue, which is there may not be enough teachers of any topic in a country. And that takes political will often when they're working for government institutions, that the funding is in the right place to pay for enough teachers, and also that there are enough opportunities for midwives or nurses to undertake additional training to be teachers. So one thing that can support this is having that, if you are working with donors or other NGOs, is that having the training of faculty as part of that is really important. We can't just implement an education program without training the teachers. And the other option is that as midwives, if there are opportunities for you to start being the provider of training, taking that up, because we learn more when we teach other people. And maybe if you were thinking about being faculty in the future, you're gaining those skills yourselves as an individual earlier on in your career. Thank you.
Thank you. Really good point, Stephanie. Do we have one more, Kristen?
Yes, not from the chat, but this is actually a question that I have, which is, working in fragile and humanitarian settings as a midwife, how do midwives engage and build trust within the communities they serve, especially with displacement or other insecurity or, change in providers? What are some ways that you who've worked, in these settings have been able to build trust and rapport with the women that you serve?
Maybe for Rita? Rita, can you take that one?
Yes. During the crisis, it's difficult to build a relationship, but by clear listening to the women and providing the opportunity for her to speak and to tell us about her feeling, and maintaining the patient privacy, this will make a good relationship between the woman and midwife. Also, when the women see that the midwife is highly educated and well trained, and she dedicated at her work and doing her best to provide the care for the women, this will make a good relationship between midwife and the woman.
Thank you so much, Rita. And I mean, you really bring out the essence of what we want midwives to be, and that's sensitive to the feelings of the women and to her experience. So thank you for that.
Thank you.
I think that our time is almost up, and I want to really thank everybody who came and everybody who asked questions, all the midwives who I think are in the audience, and then of course our experts. I can't help but just be very grateful for Rita, who's really, I think, our biggest heroine here on the ground doing the work. And it's very touching, but also the wisdom and insight from Dr. Poonam and all of her years of experience. And Stephanie, so sharp to understand the terrain of midwifery at all different levels, but particularly in the field and in humanitarian context. So just a big thank you to everyone for being here. And should I turn it over to Rachel?
Sure, and I just want to say a big thank you for hosting us, Rondi.
My pleasure.
It was lovely to learn with everyone today. This is the end of our webinar. We will follow up with any leftover questions over email, and we will send the video link to everyone who registered as well. So thank you again to all of our speakers and our audience. It was wonderful to be with you all today, and we hope you have a great rest of your days.